So, Dr. Pagadapati, why is it that these drugs are not being given? So is it that the doctors are not up to date on protocols? Care is more complex and it's just too much? Or is it a patient issue?
Yes. That's
Okay, next question. She was listening. Yeah.
sort of to be brief, it is all of those things, and that's why you saw with Coordinate Diabetes we had an incredibly intensive intervention. It was really focused on the clinician, and it did great, but it's still only a third of patients got to where they needed to be, and that's because anything that we do is going to have to focus on patient level barriers and the barriers that individuals face to getting on appropriate therapies, clinician level barriers, and then also system level barriers. And anything that just focuses on one will only go so far.
Okay, please state your name and institution.
So first of all, great session. Thanks to everybody. I'm very interested in your thoughts about how we might leverage the powers of the electronic health record to guide clinicians to do the right thing.
It's such a great question. And so people have been trying to do this now for a while, and it started with the, the dreaded BPA, the dreaded best practice alert. And I think and I'm interested to hear what Karam and others think about this. I think it's pretty well established now that we hate BPAs and they don't work by themselves, right? Like in and of itself, well, that's not totally true. The prompt trial showed a little bit. It's one of these things that like is a cheap intervention that you can do that will help a little. And then Coordinate is something that's more expensive, but will help a lot. It's deep and narrow. So I think that there are ways that it can potentially help. In and of itself, though, I think what we're learning is that just putting a notice, just kind of alerting somebody that something's not right in the electronic health record, unfortunately, isn't enough. It has to be paired with education about what to do differently. And I think, frankly, a system level issue of the time to do that, right? Clinicians want to do the right thing. It's that we've got a system that doesn't allow us to do that. So there's promise there, but there's probably more than, we need more than just that.
Sure. Yes.
Oh, I just wanted to ask Dr. Sharma real quickly, and I may have missed this, you may have said this, but your Brighter Bites program, so is that supplying all that food that didn't make the cut, so to speak? That is what is supplying the food boxes that you're handing out to different populations?
Yeah, I mean, essentially the non-sexy part of Brighter Bites is that we've created an alternative supply chain framework that allows to pull the produce that would otherwise be thrown away.
And are the farmers, are they compensated for that?
Yeah, that's a great question. So what we've leveraged are some of the so they can do it as a tax write-off.
Right.
And it's a tax write-off for also the food distribution. So Brighter Bites does not own a single warehouse or a truck. We actually work with for-profit companies like Cisco Foods, and they can use it as a tax write-off as well to pull the produce and bring it into local food banks. And then we pay the food banks to essentially do the inventory of the produce. So we are leveraging all the expertise along the way of people who've already done it.
Okay, great, thank you.
Go ahead, yes.
One question for Dr. Neha. Thank you so much, by the way, for the presentation. The biggest issue that we face at our clinic is not necessarily the prescription, it's the compliance.
Yeah.
So have you looked into what could work for patients in taking that step further?
Yeah, we have, and thank you. That's an excellent point, because just writing the prescription is necessary but not sufficient, right? There are like then a million steps along the way where the patient has to make that choice every single day, not just make that choice, but be able to get access to the medication and so forth. Actually, in Coordinate, it was interesting. It wasn't the primary outcome, but we did look at levels of adherence, at patient-reported adherence, and the patient-reported adherence was really high. But you're right, we have to take that next step. And actually, that test-to-treat program that I was just talking about is doing exactly that, with the idea that when patients leave the hospital, it's a very high risk time for them, right? They have to get new prescriptions, they have to get access to it, it can be expensive and so forth. If they have a care navigator who could be an MA, it could be a nurse, it could be anybody, right? If they have a care navigator who's working with them to identify what the issues are to adherence, whether that's not able to get the medicines, not wanting to take it, not understanding why they're taking it, can that actually help to improve the level of adherence and then the ultimate LDL control? So that is one of the things that we're testing right now in the Test to Treat program. Is an excellent point.